Welcome to this audiobook entitled Lung Abscesses. As a way of introduction, a lung abscess is a thick-walled, localized collection of pus within the lung parenchyma. Characterized by necrosis of pulmonary tissue and formation of cavities of more than 2 cm in diameter, a lung abscess is mainly caused by bacterial infection. A lung abscess differs from necrotizing pneumonia, though each has a similar pathologic process with several small cavities less than 2 cm in diameter in contiguous areas of the lung, and from empyema, which is the accumulation of pus in the pleural space. A lung abscess is a polymicrobial infection, with anaerobic bacteria present in up to 2/3 of cases, often making the infection difficult to manage. Lung abscess can be classified on the basis of symptom duration, causative pathogen, presence of foul odor of the expectorated sputum, and presence or absence of commonly associated conditions, as shown in box 1-1. This chapter provides a brief update on the epidemiology, pathophysiology, risk factors, clinical presentation, and microbiology of lung abscesses. It also focuses on the pharmacologic management of these infections. In addition, surgical options, prevention, and antimicrobial stewardship strategies are discussed. Regarding the epidemiology, the frequency of lung abscess in the general population is unclear. Because of an increased risk of periodontal disease, the older adult male population is disproportionately affected. Immunocompromised patients are also affected. A case series from an urban center with a high prevalence of alcoholism reported a mean age of 41 years for developing a lung abscess, Moreira 2006. Lung abscess-related deaths declined from 75% in the early 20th century to 20% with open drainage, further declining to 8.5% with the advent of antibiotic therapy, according to Kuhaja 2015. The available published data suggest an estimated incidence of 0.7 per 100,000 hospital admissions per year in the pediatric population, according to Ruggieri 2016. Regarding its pathophysiology, the pulmonary parenchyma is protected by defense mechanisms such as mucus secretions, ciliated epithelium, branches of the tracheobronchial tree, and the cough reflex. Offending pathogens are usually destroyed by activated cellular and humoral systems, causing an inflammatory response. If these defense mechanisms are impaired, an infection may occur. In lung abscess, the inoculum, usually from the gingival crevice, reaches the lower respiratory tract, and an infection begins. The infection is started by the non-clearance of bacteria because of altered consciousness or because the bacterial load is too large as the result of dysphagia. This results in aspiration pneumonitis, often on the right side, which then evolves to tissue necrosis 7 to 14 days later. Tissue necrosis leads to the formation of a lung abscess and/or empyema, according to Lorber 2016. Patient positioning has been associated with the anatomic location of the lung abscess. Gravity carries aspirated bacteria to dependent portions of the lungs. When the patient is in the reclining or supine position, aspiration usually occurs, according to Lorber 2016. Given that the right main stem bronchus has a wider diameter and is shorter and less angulated from the trachea than the left main stem bronchus, the lung abscess is typically unilateral and usually occurs in the posterior segment of the right upper lobe. The lung abscess is followed by the posterior segment of the left upper lobe and then by the superior segments of the lower lobes. Vomiting and aspiration in the prone position involve the middle lobe, especially in patients with alcohol abuse, according to Kuhaja 2015. Amoebic lung abscess typically occurs in the right lower lobe, according to Lorber 2016. One unique mechanism for lung abscess occurs in Lemierre disease, which is an infection of the lateral pharyngeal space of the neck caused by Fusobacterium necrophorum. Lemierre disease develops as a complication of bacterial tonsillar or peritonsillar abscess resulting in septic thrombophlebitis of the internal jugular vein. In turn, this can cause septic pulmonary emboli, according to Yazbek 2014. Tricuspid valve endocarditis associated with intravenous drug abuse, and caused by Staphylococcus aureus, typically results in bilateral septic pulmonary emboli, according to Hussein 2017. Pause the video and carefully scrutinize box 1-1 summarizing classification of lung abscess. Pause the video and carefully scrutinize Figure 1-1 summarizing chest radiograph of a patient with lung abscess in the left upper lobe. Pause the video and carefully scrutinize box 1-2 summarizing the causative pathogens for lung abscess. Regarding the risk factors, according to a published case series, a male predominance is reported with a 5-to-1 ratio, according to Yazbek 2014. Typically, patients who develop a lung abscess have a predisposition to aspiration of oropharyngeal secretions. These secretions occur because of the following: an altered level of consciousness, e.g., alcohol or drug abuse, dysphagia associated with gastroesophageal reflux disease or neuromuscular disorders with bulbar dysfunctions, Parkinson disease, stroke, mental retardation, depressed cough reflex, malnutrition or cachexia, or mechanical ventilation, intubation and/or because of drugs such as corticosteroids and immunosuppressants, and other conditions such as diabetes mellitus, sepsis, and aerobic necrotizing pneumonias. Patients with a lung abscess usually have dental or periodontal infections such as gingivitis with bacterial concentrations of more than 10^11 cells per milliliter, which commonly occur with advanced age. In edentulous or toothless patients, lung abscesses are less likely to occur. If diagnosed, however, lung abscesses may be associated with bronchial occlusions such as tumors, according to Lorber 2016, and Clotu 2015. Regarding its clinical presentation, lung abscesses and pneumonia cannot be differentiated with early signs and symptoms, according to Lorber 2016, and Kuhaja 2015. Clinical manifestations of lung abscess caused by anaerobic or mixed bacteria include nonspecific signs and symptoms for several weeks or longer. The signs and symptoms mimic tuberculosis. When aerobic pathogens cause the infection, clinical progression tends to be more rapid and usually results in non-resolving pneumonia, according to Lucari 2015. Physical examination reveals fever without rigors, poor dentition, gingival disease, halitosis, decreased breath sounds, coarse inspiratory crackles, absent gag reflex, and possibly a pleural friction rub. Nail clubbing, anemia, and a leukocytosis more than WBC 15 × 10^3 cells per millimeter cubed mainly appear in patients with a chronic lung abscess, according to Kuhaja 2015, Lucari 2015, and Yazbek 2014. Chest radiography often reveals an irregular-shaped, thick-walled cavity with an air fluid level that may not be observed in the early stages, as shown in Figure 1-1. Computed tomography is more sensitive than radiography. CT can detect small cavities and obstructing endobronchial lesions. It can also distinguish lung abscesses from air fluid levels in the pleural space, as shown in Figure 1-2, according to Mustafa 2015. An air fluid level is a sharp flat horizontal line representing the interface between the gas density above the level and the fluid density in Figure 1-1. Next we will discuss its microbiology. Depending on whether the host is immunocompromised, the microbiology of lung abscesses varies considerably, as shown in box 1-2. We will now take a closer look at the immunocompetent host. In the immunocompetent host, the oral anaerobic bacterial flora present in the gingival crevice during aspiration usually cause the resulting lung abscesses. The most commonly isolated bacteria are Peptostreptococcus species, now Feingoldea magna, Bacteroides species, usually not Bacteroides fragilis, Fusobacterium nucleatum, and Prevotella melanogenica. Anaerobes occur in about 90% of lung abscesses and are the only organisms present in 50% of cases, according to Lauber 2016. Lung abscesses are often polymicrobial and may contain 3 or 4 anaerobic species per culture specimen, according to Lauber 2016, and Yazbek 2014. Actinomycosis is a rare, chronic, and slowly progressive bacterial infection that induces suppurative and granulomatous inflammation. Actinomycosis is characterized by swelling, sinus tract formation, and purulent discharge containing yellowish sulfur granules. Actinomyces species is the most common commensal anaerobic bacterium in the human oral cavity, and 6 species are pathogenic in humans. A. israeli, the most common, Actinomyces nasalandi, Actinomyces odontolyticus, Actinomyces viscosus, Actinomyces mayeri, and Actinomyces gerenxerii. The organism is filamentous, branching, gram-positive, pleomorphic, non-spore-forming, non-acid fast, anaerobic, or facultative bacillus. Pulmonary actinomycosis is often reported in Korea and is commonly diagnosed late or misdiagnosed as tuberculosis, lung abscess, or lung cancer, according to Kim 2013. The most common aerobic organisms are Streptococcus malariae and other aerobic and microaerophilic streptococcus such as Streptococcus pneumoniae serotype 3I and Streptococcus aeruginosus complex. These streptococci can cause monomicrobial lung abscess but are usually isolated in mixed infections with anaerobes, according to Lauber 2016. Less commonly, Staphylococcus aureus, including MRSA, can cause lung abscess, which tends to present as a fulminant disease with high mortality in adolescents, young patients, and people who abuse intravenous drugs. A negative nasal screen is associated with a decreased risk of MRSA lung infections, according to Khalil 2016. Other bacteria such as enteric gram-negative bacilli e.g., Escherichia coli and Klebsiella pneumoniae, Burkholderia pseudomorlae, melioidosis, Pastorella multocida, Pseudomonas aeruginosa, and Haemophilus influenza types B and C can also cause lung abscess. In Taiwan, Klebsiella pneumonia was the predominant bacterium isolated with only 31% anaerobes, according to U 2006. Pause the video and carefully scrutinize Figure 1 to 2 summarizing CT scan of a patient with lung abscess in the left upper lobe. Next we will discuss the immunocompromised host. In patients with impaired cell-mediated immunity, such as those with HIV, AIDS, the microbiology of lung abscess commonly includes Enterobacteriaceae, such as Escherichia coli, Klebsiella pneumo-NIAE, and Enterobacter cloaca, and other gram-negative rods, abbreviated as GNRs, such as Pseudomonas aeruginosa. In hospitalized patients, oropharyngeal colonization with Pseudomonas aeruginosa and other GNRs and, to a lesser extent, Staphylococcus aureus, is common, especially in mechanically ventilated patients. Legionella pneumophila and Legionella macdadae have been associated with lung abscess formation, with Legionella macdadae having a greater propensity, according to Down 1992. Legionella species lung abscess has also been reported in immunocompetent patients, according to Deskowers 2013. Nocardia species, a gram-positive bacterium commonly found in soil and in the oral microflora of healthy gingiva and periodontal pockets, can also cause lung abscess in this patient population. Nocardia species resembles Actinomyces because it is rod-shaped. By contrast, however, Nocardia species is aerobic and will yield positive results on partly acid-fast staining. Aerobic bacteria, such as Pseudomonas aeruginosa and Staphylococcus aureus, and fungi, including Aspergillus species and zygomycetes, may cause lung abscesses in patients with granular cytopenia, whereas Nocardia species seems to be associated with long-term corticosteroid therapy, according to Yazbek 2014. Rhodococcus equi can also cause lung abscess in patients with cell-mediated immunodeficiency, e.g. AIDS and transplant-related immunosuppression, Lorber 2016. In addition to bacteria, yeasts such as Cryptococcus species, molds such as Aspergillus species, and dimorphic fungi such as Blastomyces, Coccidioides, and Histoplasma species can cause lung abscess in patients who are immunocompromised. Lung abscess caused by pulmonary candidiasis is rare, with only one case reported in India over the past decade, according to Gupta 2006. Cryptococcal meningitis is often associated with disseminated disease, which is the most common presentation among individuals with compromised immune systems, according to Gatkovsky 2008. Allergic bronchopulmonary aspergillosis usually occurs in people who have cystic fibrosis or asthma. Aspergillomas usually affect people who have other lung diseases such as tuberculosis. Chronic pulmonary aspergillosis typically occurs in people who have other lung diseases, including tuberculosis, chronic obstructive pulmonary disease, or sarcoidosis. Invasive aspergillosis affects people who are immunocompromised, according to the CDC 2015. Aspergillus fumigatus is commonly implicated in lung abscess formation in immunocompromised patients. Case reports on blastomyces-induced lung abscess are scarce. Pulmonary findings of coccidioidomycosis are miliary nodules and confluent parenchymal opacities. Risk factors for the disease include immunocompromised status such as HIV infection, immunosuppressive drugs, and high-dose glucocorticoid administration, according to Jude 2014. Disseminated histoplasmosis usually occurs in immunocompromised hosts, particularly individuals with advanced HIV infection, and usually does not cause cavitary lung lesions, according to Gatkovsky 2008. Lung abscess caused by Mycobacterium tuberculosis has been reported in patients with cavitary bronchiogenic carcinoma, according to Sehan 1993, and in pediatric patients exposed to contagious sources, according to Agarwal 2014. Non-tuberculous atypical mycobacteria are also associated with lung abscess. These include, Mycobacterium avium complex, abbreviated as MAC, Mycobacterium kansasi, Mycobacterium simii, Mycobacterium abscessus, Mycobacterium fortuatum, and Mycobacterium shalloni. In general, non-tuberculous atypical mycobacteria occur more commonly in women, in older adults, and in the West and Southeast. In the United States, whites account for 90% of cases, followed by Asians, Pacific Islanders and blacks. In the United States, Mycobacterium kansasi usually occurs in southern and central regions and in non-endemic areas with substantial HIV disease. In addition to others, Mycobacterium abscessus is usually identified in the southeastern United States from Florida to Texas, according to Johnson 2014. Parasites such as Entamoeba histolytica and Paragonomus westermanni can also cause lung abscesses. Pulmonary amoebiasis is rare and is commonly associated with amoebic liver abscess. Pulmonary amoebiasis occurs in 2% to 3% of patients with invasive amoebiasis, especially with low socioeconomic status, malnutrition, and chronic alcoholism. The disease mainly affects the developing countries. The largest burden caused by Entamoeba histolytica infection occurs in Africa, Central and South America, and the Indian subcontinent, according to Shenoy 2010. Paragonimiasis is a foodborne, zoonotic illness caused by trematodes that is often confused with tuberculosis. Paragangliomyces is mainly present in Southeast Asia and, to a lesser extent, Central Africa and South America, according to Kunst 2011. Next we will discuss treatment. The goals of therapy for lung abscesses are to eradicate the causative organisms, alleviate signs and symptoms, avoid complications, prevent recurrences, and minimize the transmission of potentially infectious organisms. The general approach to treatment is antimicrobial therapy targeted against the most likely or isolated pathogens, with interventional procedures and surgeries reserved for complicated cases. Mild to moderate infections are often treated with oral antimicrobials in the outpatient setting. Moderate to severe infections are treated with parenteral antimicrobials first, followed by oral antimicrobials when the patient's condition becomes stable, according to Lorber 2016. Regarding bacterial lung abscess, Figure 1-3 shows the general approach to managing bacterial lung abscess, and Table 1-1 lists the antibiotics used to treat these abscesses. The American Thoracic Society, abbreviated as ATS, and the Infectious Diseases Society of America (IDSA) released joint guidelines for managing community-acquired pneumonia, according to Mandel 2007, and hospital-acquired pneumonia, according to Khalil 2016, but no guidelines specifically address managing lung abscesses. Regarding the empiric therapy, empiric antibiotic therapy directed against oral anaerobes, streptococci, and some GNRs is the standard of care in immunocompetent patients. Amoxicillin, clavulanate and penicillin VK plus clindamycin or metronidazole are administered orally in patients presenting with mild to moderate infections. Cephalexin or cefuroxime plus clindamycin or metronidazole are alternative oral agents in patients with mild allergies to penicillin. Although clindamycin is not active against GNRs, it is used in patients presenting with mild to moderate infections, particularly in patients allergic to beta-lactams. Moxifloxacin is another alternative for these patients and has the advantage of excellent oral bioavailability. Ampicillin, sulbactam, cefhoxetine, and ceftriaxone plus clindamycin or metronidazole are administered intravenously in patients presenting with moderate to severe infections. Ertapenem is an alternative for these patients and has the advantage of once-daily parenteral administration, which is useful in the outpatient setting. Piperacillin, tazobactam, imipenem, cilastatin, and meropenem are reserved for patients presenting with severe infections, particularly patients at risk of infection with drug-resistant GNRs, according to Lorber 2016, and Kuhajda 2015. Pause the video and carefully scrutinize Figure 1-3 summarizing the general approach to the management of bacterial lung abscess. Pause the video and carefully scrutinize Table 1-1 listing the antibiotics used to treat bacterial lung abscess. Pause the video and carefully scrutinize Table 1-1 listing the antibiotics used to treat bacterial lung abscess. Pause the video and carefully scrutinize Table 1-1 listing the antibiotics used to treat bacterial lung abscess. Pause the video and carefully scrutinize Table 1-1 listing the antibiotics used to treat bacterial lung abscess. Pause the video and carefully scrutinize Table 1-1 listing the antibiotics used to treat bacterial lung abscess. Next we will discuss anaerobic organisms. Resistance to penicillin and clindamycin is increasing globally, even though susceptibility testing of anaerobes is not commonly performed in laboratories. Metronidazole should not be used as monotherapy because of its poor activity against oral anaerobes such as Actinomyces, Peptostreptococcus, and Propionibacterium. However, metronidazole retains excellent activity against many gram-negative anaerobes such as Bacteroides species and has a more favorable adverse event profile than clindamycin, according to Schutz 2014. Regarding Staphylococcus aureus, oxacillin and nafcillin are the drugs of choice for patients with proven MSSA abscesses, whereas linezolid and vancomycin are the drugs of choice for patients with suspected or proven MRSA abscesses. Higher vancomycin serum concentrations may be necessary to achieve appropriate lung concentrations, whereas linezolid has adequate lung penetration and the ability to shut down toxin production at usual doses, according to Stein 2015. Daptomycin should not be used to treat lung abscesses because it binds to, and is inactivated by, pulmonary surfactant. Trimethoprim, sulfamethoxazole, clindamycin, or doxycycline can be used in patients with susceptible community-associated MRSA infections, depending on local susceptibility patterns and patient characteristics, according to Liu 2011. Regarding Streptococcus pneumoniae, ceftriaxone is the drug of choice for lung abscesses caused by Streptococcus pneumoniae, whereas levofloxacin is an alternative in patients allergic to beta-lactams. Vancomycin and linezolid are reserved for multi-drug-resistant streptococcal infections, according to Mandel 2007. Regarding Pseudomonas aeruginosa, piperacillin, tazobactam, ceftazidime, cefepime, imipenem C. lastatine, and meropenem are considered the drugs of choice for lung abscesses caused by Pseudomonas aeruginosa. Aztaranem is reserved for patients allergic to beta-lactams. Ciprofloxacin, levofloxacin, gentamicin, and tobramycin are sometimes added empirically to anti-pseudomonal beta-lactams, depending on the local antibiogram, until microbiology and susceptibility reports become available. Amikacin is reserved for resistant strains, and polymyxin B and colistin are reserved for multidrug-resistant strains, according to Khalil 2016. Aiming for aggressive dosing of aminoglycosides to overcome penetration into lung tissues and abscesses is impractical because of their toxicity profile, according to Jamal 2013. And now we will discuss miscellaneous organisms. Azithromycin and levofloxacin are the drugs of choice for lung abscesses caused by Legionella pneumophila, whereas doxycycline is an alternative in patients unable to receive macrolides or fluoroquinolones, according to Cunha 2017, and Mandel 2007. Trimethoprim, sulfamethoxazole is the drug of choice for lung abscesses caused by nocardia asteroides, whereas imipenem cilastatin is an alternative. Amikacin is added to trimethoprim, sulfamethoxazole or imipenem cilastatin in severe and disseminated cases, Welch 2013. Next we will discuss the therapy duration. The optimal therapy duration for lung abscess is unclear, but most references recommend 6 to 8 weeks of therapy. One study using clindamycin showed no difference between 3 and 6 weeks of therapy for an anaerobic lung abscess, according to Levison 1983. Patients are expected to improve within a few days after starting antibiotic therapy, with fever normalizing within 7 to 10 days. Putrid sputum and the abscess should resolve within 5 to 21 days of antibiotic therapy. If fever persists beyond 2 weeks of therapy, clinicians should suspect complications, which may necessitate non-pharmacologic approaches. Different antimicrobial regimens may be necessary for unusual pathogens. Chest radiography should be monitored weekly or bi-weekly and antibiotic therapy discontinued when the radiograph is clear or contains a small residual lesion, according to Lorber 2016, and Kuhajda 2015. Therapy duration for pulmonary nocardiosis is 6 to 12 months, according to Welch 2013. Next we will discuss mycobacterial lung abscess. Figure 1 to 4 shows the general approach to managing mycobacterial lung abscess, and Table 1 to 2 lists the antimycobacterials used to treat these abscesses. The ATS/IDSA released joint guidelines for managing tuberculosis, NAHED 2016, and non-tuberculous atypical mycobacteria, according to Griffith 2007. Regarding M. tuberculosis, isoniazid plus rifampin plus pyrazinamide plus ethambutol daily, or 5 days per week, for 8 weeks, followed by isoniazid plus rifampin daily, or 5 days per week for 18 weeks, is the regimen of choice for pulmonary tuberculosis. Isoniazid plus rifampin plus pyrazinamide plus ethambutol daily, or 5 days per week, for 8 weeks, followed by isoniazid plus rifampin 3 days per week for 18 weeks is the preferred alternative regimen when directly observed therapy is difficult to achieve. Isoniazid plus rifampin plus pyrazinamide plus ethambutol 3 days per week for 8 weeks, followed by isoniazid plus rifampin 3 days per week for 18 weeks should be used with caution in patients with HIV and/or cavitary disease. Isoniazid plus rifampin plus pyrazinamide plus ethambutol daily for 2 weeks, then for 2 days per week 6 weeks, followed by isoniazid plus rifampin for 2 days per week for 18 weeks should be avoided in patients with HIV or smear-positive and/or cavitary disease. Pyridoxine should be given with isoniazid to decrease the risk of developing neuropathy in selected patients, as shown in box 1 to 3. Ethambutol can be discontinued as soon as laboratory studies show susceptibility to isoniazid and rifampin, according to Nahid 2016. In case of resistance, second-line drugs for tuberculosis can be used. Commonly used second-line agents include cycloserine, ethionamide, streptomycin, amikacin, kanamycin, capreomycin, para-aminosalicylic acid, levofloxacin, and moxifloxacin, according to Nahid 2016. Directly observed therapy improves treatment success, sputum conversion, and early recognition of adverse drug reaction. For these reasons, it is the standard of practice in most U.S. programs, according to Nahid 2016. Drug-induced hepatitis requires the offending drugs to be discontinued and replaced with drugs from a different class. Isoniazid, rifampin, and pyrazinamide can cause hepatitis if the ALT concentration is 3 times or more the upper limit of normal in the presence of symptoms, or if the ALT concentration is 5 times or less the upper limit of normal in the absence of symptoms. Therapeutic drug monitoring may be helpful in patients with poor response, severe GI upset, drug interactions, renal impairment, HIV co-infection, and diabetes, and if using second-line agents. Monitoring patients receiving rifamycins or antiretrovirals for drug interactions is warranted, according to Nahid 2016. Next we will discuss Mycobacterium avium complex, abbreviated as MAC. A multidrug regimen consisting of a macrolide, clarithromycin or azithromycin, plus a rifamycin, rifampin or rifabutin, plus ethambutol for 12 months is the regimen of choice for pulmonary infections caused by MAC. An aminoglycoside, amikacin or streptomycin, should be added for the initial 2 to 3 months in patients with extensive or severe infections. Rifabutin plus ethambutol plus amikacin or streptomycin is an alternative regimen in patients with macrolide-resistant infections, according to McShane 2015, and Griffith 2007. Regarding Mycobacterium kansasi, isoniazid plus rifampin plus ethambutol for 12 months is the regimen of choice for pulmonary infections caused by Mycobacterium kansasi, whereas clarithromycin plus rifampin plus ethambutol is an alternative regimen. Intermittent administration 3 times per week offers the advantage of improved tolerability and cost but may be inappropriate in patients with cavitary disease, according to McShane 2015, and Griffith 2007. Next we will discuss fungal lung abscesses. Figure 1 to 5 shows the general approach to managing fungal lung abscesses, and Table 1 to 3 lists the antifungals used to treat these abscesses. The ATS has released a statement on the treatment of fungal infections in adult pulmonary and critical care patients, according to LIMPA 2011, and the IDSA has released guidelines for managing cryptococcosis, Perfect 2010, aspergillosis, Patterson 2016, blastomycosis, according to Chapman 2008, histoplasmosis, according to Wheat 2007, and coccidioidomycosis, according to Galgiani 2016. Next we will discuss Cryptococcus species. The drug of choice for mild to moderate pulmonary cryptococcosis is fluconazole for 6 to 12 months. Itraconazole, voriconazole, and posaconazole are alternative agents. Amphotericin B deoxycholate plus flucytosine for at least 2 weeks followed by fluconazole for at least 8 weeks followed by maintenance therapy with fluconazole for 12 months is the preferred regimen for severe disease. Lipid formulations of amphotericin B can be used instead of amphotericin B deoxycholate to decrease the risk of adverse events. Corticosteroids may be considered in the presence of acute respiratory distress syndrome or immune reconstitution inflammatory syndrome. Signs and symptoms of immune reconstitution inflammatory syndrome can be localized or systemic and often include fever. Signs and symptoms are associated with paradoxical worsening of pre-existing infections in patients with AIDS. Fluconazole is the drug of choice for small cryptococcosis, whereas amphotericin B deoxycholate plus flucytosine for 4 to 6 weeks followed by fluconazole for 6 to 18 months is the regimen of choice for large and multiple cryptococcosis. Surgery may be considered if there is compression to vital structures or if there is no reduction in size after 4 weeks of therapy, according to Perfect 2010. Next we will discuss Aspergillus species. Voriconazole for at least 6 to 12 weeks is the preferred drug for invasive pulmonary aspergillosis. Liposomal amphotericin B and isavuconazole are alternative agents. Amphotericin B lipid complex, caspofungin, micafungin, posaconazole, and itraconazole suspension are used as salvage therapy. Although combination therapy is not routinely recommended, adding another agent such as an echinocandin may be considered in patients with severe disease, especially in those with hematologic malignancy and those with profound and persistent myelosuppression. No therapy is needed for asymptomatic patients with chronic cavitary pulmonary aspergillosis. Voriconazole or itraconazole for at least 6 months is the regimen of choice for symptomatic patients. Posaconazole is an alternative agent. No therapy or surgical resection is needed for asymptomatic patients with aspergilloma. Resection is recommended for a single aspergilloma in symptomatic patients. Voriconazole or another mold-active azole is recommended if there is a moderate risk of spillage of the aspergilloma during surgical resection. Amphotericin B may not be effective in this setting because of its poor penetration into pre-existing cavities, according to Patterson 2016. Pause the video and carefully scrutinize Figure 1 to 5 summarizing general approach to the management of fungal lung abscess. Agents in bold represent the drug or regimen of choice. Pause the video and carefully scrutinize Table 1 to 2 summarizing antimycobacterials used to treat lung abscess. Pause the video and carefully scrutinize Box 1 to 3 summarizing conditions that increase the risk of isoniazid-induced neuropathy. Pause the video and carefully scrutinize Figure 1 to 5 summarizing the general approach to the management of fungal lung abscess. Agents in bold represent the drug or regimen of choice. Pause the video and carefully scrutinize Table 1 to 3 summarizing the antifungals used in the treatment of fungal lung abscess. Pause the video and carefully scrutinize Table 1 to 3 summarizing the antifungals used in the treatment of fungal lung abscess. Regarding blastomyces species, itraconazole for 6 to 12 months is recommended for patients with mild to moderate pulmonary blastomycosis. Amphotericin B deoxycholate or lipid formulations of amphotericin B for 1 to 2 weeks followed by itraconazole for a total of 6 to 12 months is recommended for patients with moderate to severe infection, according to Chapman 2008. Regarding histoplasma species, although antifungal therapy is unnecessary in patients with mild to moderate pulmonary histoplasmosis, itraconazole for 6 to 12 weeks is recommended for patients who are symptomatic for more than 1 month. Amphotericin B deoxycholate or lipid formulations of amphotericin B for 1 to 2 weeks followed by itraconazole for a total of 3 months is recommended in patients with moderate to severe acute pulmonary histoplasmosis. Corticosteroids are recommended in patients who develop complications. Itraconazole for at least 12 months is recommended in patients with chronic cavitary pulmonary histoplasmosis. Antifungal therapy is not recommended for patients with histoplasmosis, according to Wheat 2007. Regarding coccidioides species, antifungal therapy is usually unnecessary in patients with asymptomatic, uncomplicated coccidioidal pneumonia or in those with a pulmonary nodule or cavity. However, fluconazole is recommended in patients with comorbidities such as diabetes or advanced age. Fluconazole or itraconazole is recommended in patients with symptomatic cavitary coccidioidal pneumonia. Surgery can be considered if cavities have been present for more than 2 years and/or if symptoms recur when antifungal therapy is discontinued. Azole antifungals are the preferred drugs in patients with ruptured coccidioidal cavities, whereas amphotericin B is an alternative agent. Fluconazole is recommended for the treatment of acute or chronic pulmonary coccidioidomycosis in immunocompromised patients who are clinically stable. Amphotericin B followed by fluconazole is recommended for the treatment of severe pulmonary coccidioidomycosis in immunocompromised patients, according to Galgiani 2016. Next we will discuss parasitic lung abscesses. Antiparasitics are used for lung abscesses caused by Entamoeba histolytica, Paragonomus westermanni, and other parasites. Metronidazole and tonidazole, tissue-acting agents, are the drugs of choice for patients with amoebic lung disease. Therapy duration with metronidazole is 7 to 10 days, whereas therapy duration with tinidazole is 5 days. Paramomycin, a luminal agent, is used subsequently for 7 days to eliminate intraluminal cysts. Di-O-2-hydroxyquin and diloxanide furoate are alternative luminal agents. Praziquantel is the drug of choice for patients with paragoniomyces. The most common adverse effects associated with praziquantel are nausea and vomiting, and the most serious adverse event is anaphylactic reaction. Triclobendazole is an alternative agent that can be obtained from the CDC, according to 2014, LAL 2013, and Kunst 2011. Next we will discuss pediatric patients. Children with neurodevelopmental delays and those with lung diseases such as cystic lung lesion or cystic fibrosis are more likely to develop lung abscesses. The microbiology of lung abscesses in children is similar to that in adults, with oral anaerobic bacteria, streptococci, and staphylococci being the most common organisms, according to Madani 2016. In primary lung abscesses, the most common pathogens are Staphylococcus aureus, Streptococcus species, and gram-negative bacilli, whereas anaerobes are found in secondary lung abscesses and fungal pathogens in immunocompromised patients. Lung abscesses rarely occur in neonates, but a lung abscess may be associated with lung cysts, pneumonia, or the presence of central venous lines, according to Patradun Ho 2007. The most common regimen in children is a third-generation cephalosporin plus clindamycin. Cefotaxime is preferred to ceftriaxone in neonates because it does not interact with calcium-containing drugs and does not cause biliary sludging. Fluoroquinolones should generally be avoided in children, and tetracyclines should be avoided in children younger than 8 years. The overall outcomes and mortality rates in children with lung abscess, particularly in the absence of comorbidities, are better than those in adults, according to Madani 2016, Choi 2015, and Pulligandla 2008. Next we will consider older adult patients. Older patients are at higher risk of developing lung abscesses as the result of decreased immune response and increased risk of aspiration as the result of strokes and other neurologic disorders. Many older patients have renal impairment, which necessitates dose adjustment for many antimicrobials, see Table 1-1, Table 1-2, and Table 1-3. Older patients are more sensitive to the adverse effects of antimicrobials, particularly nephrotoxicity, neurotoxicity, and Clostridioides difficile infection, and are more likely to have tendinitis or tendon rupture when given fluoroquinolones, particularly if combined with corticosteroids. Older patients receiving several drugs for many different conditions are also more likely to have drug interaction. Next we will discuss immunocompromised patients. Patients with immunocompromising conditions and those receiving immunosuppressive drugs are more likely to present with a lung abscess caused by opportunistic bacteria, mycobacteria, and fungi. Treatment of these patients is more aggressive and requires closer monitoring for adverse effects and potential drug interactions. Next we will discuss tuberculosis and HIV. Patients with tuberculosis and HIV co-infection should receive antiretrovirals in conjunction with daily antitubercular agents to decrease the risk of mortality and AIDS-defining illnesses. Daily regimens have been associated with better outcomes than intermittent regimens. The recommended therapy duration is 6 months if the patient is receiving antiretrovirals. However, therapy should be extended to 9 months in patients not receiving antiretrovirals or in patients at risk of relapse. Antiretrovirals should be initiated within 2 weeks for patients with a CD4 count less than 50 cells per millimeter cubed and within 8 to 12 weeks for patients with a CD4 count of 50 cells per millimeter cubed or more. Patients should be monitored for drug interactions, particularly between antiretrovirals and rifamycins, and treated accordingly. Dose-adjusted rifabutin is preferred to rifampin and rifapentine to decrease the risk of drug interactions. Patients should also be monitored for immune reconstitution inflammatory syndrome, particularly when CD4 counts are less than 50 cells per millimeter cubed. Mild cases of immune reconstitution inflammatory syndrome are managed by adding anti-inflammatory agents such as ibuprofen. Severe cases are managed with prednisone. In patients with worsening pleural effusions or abscesses, drainage may be necessary, according to Nahid 2016. Next we will discuss fungal infections and HIV. Because antifungal prophylaxis for cryptococcosis is not routinely recommended in patients with HIV, antifungal therapy can be discontinued in patients with HIV when the CD4 count is more than 100 cells per millimeter cubed and a cryptococcal antigen titer is 1 to 512 or less, according to Perfect 2010. Although antifungal prophylaxis is not recommended to prevent coccidioidomycosis in patients with HIV, antifungal therapy should be initiated in patients with a CD4 count less than 250 cells per millimeter cubed and should be continued as long as the CD4 count remains less than 250 cells per millimeter cubed, according to Galgiani 2016. Antifungal prophylaxis with itraconazole is recommended in patients with HIV living where the incidence of histoplasmosis is more than 10 cases per 100 patient years when the CD4 count is less than 150 cells per millimeter cubed according to Wheat 2007. And now we will look at non-pharmacologic approaches. Antimicrobials are the mainstay of therapy for lung abscesses. Bronchoscopy is used to assist in diagnosing and managing select cases. Conditions in which bronchoscopy is recommended are summarized in box 1 to 4. Unlike other types of abscesses, lung abscesses do not typically require drainage because they often rupture spontaneously into the airways. The percussion and positioning will increase drainage through the airways. Drainage of a large amount of pus and necrotic material may result in spread of the infection to other parts of the lung, asphyxiation, or acute respiratory distress syndrome. The CT-guided percutaneous drainage and endoscopic placement of a pigtail catheter with antibiotic irrigation are recent advances in the non-pharmacologic approaches to managing lung abscesses. Surgery is reserved for the 10% to 15% of cases that do not respond to antimicrobials. Conditions in which lobectomy or pneumonectomy is recommended are summarized in box 1 to 5, according to Lorber 2016, Kuhajda 2015. Pause the video and carefully scrutinize box 1 to 4 summarizing conditions for which bronchoscopy is recommended and box 1 to 5 summarizing conditions for which lobectomy or pneumonectomy is recommended. Next we will discuss the newly introduced antimicrobials. Regarding bedaquiline, an antimycobacterial drug introduced in 2012, has a labeled indication for the treatment of adults with pulmonary multidrug-resistant tuberculosis as part of combination therapy when an effective regimen cannot otherwise be provided. The approval of bedaquiline was largely based on phase 1 and 2 studies, with time to sputum conversion at week 8 as the primary endpoint, according to Chahini 2014. Bedaquiline is not commonly used in the United States because its adverse effect profile includes boxed warnings related to increased mortality and QT prolongation. Monitor ECGs and discontinue bedaquiline if significant ventricular arrhythmia occurs or if the QTc interval exceeds 500 milliseconds. Like many antitubercular agents, bedaquiline is associated with hepatotoxicity. Monitor liver function tests, and discontinue bedaquiline if aminotransferase elevations are accompanied by total bilirubin elevation greater than 2 times the upper limit of normal, aminotransferase elevations are greater than 8 times the upper limit of normal, or aminotransferase elevations are greater than 5 times the upper limit of normal and persist beyond 2 weeks. Bedaquiline is a CYP3A4 substrate that interacts with strong and moderate CYP3A4 inducers and strong CYP3A4 inhibitors. The most common adverse effects include nausea, arthralgia, headache, hemoptysis, and chest pain, according to Chahini 2014. Preliminary reports suggest that bedaquiline is also effective for MAC as salvage therapy, according to Philly 2015. Next we will discuss ceftaroline. Ceftaroline, an anti-MRSA antibiotic introduced in 2010, has a labeled indication for the treatment of children and adults with acute bacterial skin and skin structure infections and community-acquired bacterial pneumonia. In 2 randomized, double-blind clinical trials, ceftaroline 600 mg intravenously every 12 hours was non-inferior to ceftriaxone 1 gram intravenously every 24 hours for 5 to 7 days in the treatment of community-acquired bacterial pneumonia, according to Taboada 2016. Although patients with MRSA infections were excluded from the pneumonia trials, ceftaroline is commonly used off-label to treat MRSA pneumonia and bacteremia. In another randomized trial not powered for efficacy, ceftaroline had a favorable efficacy and safety profile in children with community-acquired bacterial pneumonia, according to Yim 2017. The most common adverse reactions associated with ceftaroline are GI upset, rash, and pyrexia, according to Yim 2017, and Taboada 2016. Ceftaroline has excellent in vitro activity against many anaerobic organisms that can cause lung abscess, with the exception of Bacteroides species and beta-lactamase producing Prevotella species, according to Citron 2010. Next we will discuss ceftazidime, avibactam ceftazidime, an anti-pseudomonal antibiotic, combined with a novel beta-lactamase inhibitor. Avibactam was introduced in 2015. It has a labeled indication for the treatment of adults with complicated UTIs, including pyelonephritis, and in combination with metronidazole for the treatment of complicated intra-abdominal infections caused by susceptible gram-negative pathogens. Because of its broad spectrum of activity against GNRs, including Pseudomonas aeruginosa, some extended-spectrum beta-lactamase-producing Enterobacteriaceae and some carbapenem-resistant Enterobacteriaceae, ceftazidime, avibactam administered at the dose of 2.5 grams intravenously every 8 hours is currently under investigation for the treatment of hospital-acquired or ventilator-associated bacterial pneumonia. Ceftazidime, avibactam has been approved for this indication by the European Commission on the basis of a randomized, double-blind, non-inferiority clinical trial comparing it with meropenem administered at the dose of 1 gram intravenously every 8 hours, according to AstraZeneca 2016. Ceftazidime, avibactam has also been approved by the European Commission for the treatment of aerobic gram-negative infections in adult patients with limited treatment options. Ceftazidime, avibactam is contraindicated in patients with a serious hypersensitivity to ceftazidime and carries a warning of hypersensitivity reactions in patients allergic to penicillin. Ceftazidime, avibactam also carries a warning of seizures and other neurologic events, particularly in patients with renal impairment. Ceftazidime, avibactam has decreased efficacy in patients with a CR/CL of 30 to 50 ml per minute per 1.73 meters squared. The most common adverse reaction associated with ceftazidime, avibactam is GI upset, according to AstraZeneca 2016, and Chahini 2015. A published case report described the successful use of ceftazidime, avibactam 2.5 grams intravenously every 8 hours plus colistin 2 million units intravenously every 8 hours plus colistin 1 million units by inhalation every 8 hours for 18 days in the treatment of a patient with lung abscesses caused by extensively drug-resistant Pseudomonas aeruginosa. Potential advantages of this combination include synergy between both antibiotics and avoidance of resistance, according to Zifal 2017. Next we will discuss ceftolozane, tazobactam. Ceftolozane, tazobactam, a new anti-pseudomonal antibiotic combined with a well-established beta-lactamase inhibitor, was introduced in 2014. It has a labeled indication for the treatment of adults with complicated UTIs, including pyelonephritis, and in combination with metronidazole for the treatment of complicated intra-abdominal infections caused by susceptible streptococci and gram-negative pathogens. Because of its broad spectrum of activity against GNRs, including multidrug-resistant strains of Pseudomonas aeruginosa and some extended-spectrum beta-lactamase-producing Enterobacteriaceae, ceftolozane, tazobactam administered at the higher dose of 3 grams intravenously every 8 hours is currently under investigation for the treatment of hospital-acquired or ventilator-associated bacterial pneumonia. Ceftolozane, tazobactam is contraindicated in patients with a serious hypersensitivity to piperacillin, tazobactam or other beta-lactams. Ceftolozane, tazobactam has decreased efficacy in patients with a CR/CL of 30 to 50 ml per minute per 1.73 meters squared. The most common adverse reactions associated with ceftolozane, tazobactam are GI upset, headache, and pyrexia, with a higher incidence in older patients, according to Sucha 2015. A published clinical experience with ceftolozane, tazobactam suggests that the new antibiotic is effective when used as a salvage therapy for patients with pneumonia caused by multidrug-resistant Pseudomonas aeruginosa, according to Kasten 2017. Next we will discuss isavuconazole. Isavuconazole, a second-generation triazole antifungal introduced in 2015, has a labeled indication for the treatment of adults with invasive aspergillosis and mucormycosis. In a randomized, double-blind clinical trial, isavuconazole administered at the dose of 200 mg intravenously every 8 hours for the first 48 hours, followed by 200 mg intravenously or orally once daily, was non-inferior to voriconazole administered at the dose of 6 mg per kilogram intravenously every 12 hours for the first 24 hours, followed by 4 mg per kilogram intravenously every 12 hours for the following 24 hours, followed by 200 mg intravenously or orally every 12 hours in the treatment of invasive aspergillosis, according to Rybak 2015. In an open-label non-comparative trial, isavuconazole was also effective in the treatment of invasive mucormycosis, according to Rybak 2015. Unlike other azole antifungals, isavuconazole decreases the quart interval and is contraindicated in patients with familial short QT syndrome. Isavuconazole is also contraindicated in combination with strong CYP3A4 inhibitors such as ritonavir and strong CYP3A4 inducers such as rifampin, carbamazepine, and St. John's wort. Like other azole antifungals, isavuconazole is associated with hepatotoxicity, infusion reactions, and hypersensitivity reactions. The most common adverse reactions associated with isavuconazole are GI upset, headache, elevated liver function tests, hyperkalemia, dyspnea, cough, peripheral edema, and back pain, according to Rybak 2015. Next we will discuss tedazolide. Tedazolide, a new oxazolidinone antibiotic introduced in 2014, has a labeled indication for the treatment of acute bacterial skin and skin structure infections caused by susceptible gram-positive pathogens, including MRSA, in adults. Tedazolide administered at the dose of 200 mg intravenously every 24 hours for 7 days is currently under investigation for the treatment of hospital-acquired or ventilator-associated bacterial pneumonia compared with linezolid administered at the dose of 600 mg intravenously every 12 hours for 10 days. Like with linezolid, the safety and efficacy of tedazolide in patients with neutropenia have not been established. Tedazolide is a reversible inhibitor of monoamine oxidase and may interact with serotonergic and adrenergic agents, but the extent of these interactions seems less than with linezolid. Tedazolide administered orally may interact with breast cancer resistance protein substrates such as rosuvastatin and increase their concentrations. Like linezolid, tedazolide is associated with peripheral and optic neuropathy and myelosuppression, including neutropenia and thrombocytopenia. The most common adverse reactions associated with tedazolide are GI upset, headache, and dizziness, according to Janelle 2015. Next we will discuss telavancin. Telavancin, a short-acting lipoglycopeptide antibiotic introduced in 2009, has a labeled indication for the treatment of adults with complicated skin and skin structure infections caused by susceptible gram-positive pathogens and hospital-acquired or ventilator-associated pneumonia caused by susceptible isolates of Staphylococcus aureus, including MRSA, when alternative options are unsuitable. In 2 randomized double-blind clinical trials, telavancin administered at the dose of 10 mg per kilogram intravenously every 24 hours was non-inferior to vancomycin administered at the dose of 1 gram intravenously every 12 hours for 7 to 21 days, according to Leopicu 2016. Telavancin is rarely used because of its suboptimal efficacy and adverse effect profile. Televincin carries a box warning related to increased mortality in patients with hospital-acquired or ventilator-associated bacterial pneumonia and pre-existing moderate to severe renal impairment compared with vancomycin. Televincin also carries boxed warnings related to nephrotoxicity and potential fetal toxicity, such as adverse developmental outcomes. Like eritivancin, but unlike dalbavancin and vancomycin, televincin is contraindicated with intravenous unfractionated heparin and interferes with some coagulation tests. Televincin is associated with hypersensitivity reactions, infusion-related reactions, and QT prolongation. The most common adverse reactions associated with televincin are GI upset, dysgeusia, and foamy urine, according to Leopicu 2016. Next we will discuss prevention of lung abscesses. Lung abscess can be prevented by limiting alcohol use in order to avoid intoxication and subsequent aspiration, by emphasizing good oral hygiene, and by timely treatment of diseases of the oral cavity and respiratory tract. Patients with a history of esophageal disorders such as scleroderma or esophageal or gastric surgery predisposing to regurgitation should be instructed on approaches that reduce the risk of gastric content aspirations, such as elevating the head of the bed by 30 degrees during sleep and avoiding overfilling the stomach before sleeping. Early intubation should be considered in patients who have diminished ability to protect the airway from massive aspiration. Patients with dysphagia are encouraged to eat small, soft, frequent meals. Patients with neurologic disorders such as stroke should be treated to prevent aspiration and subsequent lung abscess. Finally, routine immunizations with pneumococcal, PPSV23 and PCV13, and influenza vaccines may help decrease the risk of lung infections. And finally, we will now discuss some practice points. In determining the optimal treatment of a patient with a lung abscess infection, the clinician must consider the following important points. 1. First, determine the type of the abscess, the risk factors, and whether the host is immunocompetent or immunocompromised to identify the most likely causative organisms. These elements, together with host factors such as allergies, hepatic and renal functions, and concomitant drugs, should serve as the basis for selecting an antimicrobial regimen to treat lung abscess. 2. In the immunocompetent host, treat most bacterial lung abscesses with antibiotics directed against anaerobes, streptococci, and some gram-negative rods, starting with intravenous therapy, followed by oral therapy when the patient becomes stable. 3. Recommend 6 to 8 weeks of therapy unless there are complications, which may necessitate non-pharmacologic approaches, and unless there are unusual pathogens, which may necessitate unique antimicrobial regimens. 4. In the immunocompromised host, suspect unusual bacteria, mycobacteria, or fungi and treat accordingly. 5. Suspect parasites in certain areas of the world where these parasites are endemic. 6. Recommend non-pharmacologic therapies such as drainage and surgery when antimicrobials fail or in addition to antimicrobials in severe cases. 7. Monitor patients for the effectiveness of the antimicrobial regimen and for adverse events and drug interactions, particularly during prolonged treatment. 8. Educate patients presenting with lung abscess and their caregivers about ways to prevent aspiration to decrease the risk of recurrent infections. 9. Encourage patients to receive the influenza and pneumococcal vaccines, when indicated, to decrease the risk of lung infections. And now, in conclusion, lung abscesses are encountered in both outpatient and inpatient settings. Bacteria, mycobacteria, fungi, and occasionally parasites can cause lung abscesses. Antimicrobials represent the primary treatment options in most cases. Pharmacists assist prescribers in selecting the most appropriate antimicrobial regimens, including doses, frequencies of administrations, and therapy durations, for patients presenting with lung abscesses. Pharmacists often educate patients about the importance of adhering to the prescribed antimicrobial regimens and address questions and concerns related to dosing, adverse events, and drug interactions. Pharmacists play an important role in implementing antimicrobial stewardship programs to optimize the outcomes of patients presenting with lung abscesses while decreasing adverse events, including Clostridioides difficile infection, halting antimicrobial resistance, and optimizing resource use across the continuum of care, according to Barlam 2016. Thank you.